I'll be talking about something that is really in a formative stage. It's about some of my attempts to impact healthcare in my country, and I'm hoping to get tweaks and suggestions from the floor, and also to impart some ideas, especially to the medical doctors here, on personal and group ways of trying to influence public health and healthcare generally in your countries of origin. Okay, so I'm not going to go into the details of these because in almost every talk there's been something about this, but there's approximately 140 million Africans in the diaspora and about 30 million in the West. They're located in diverse continents, in United States, Europe, Asia. They have contributed immensely to the economies of their countries of residence in all endeavors, from medical to even politics. Nigeria has an MP in the United Kingdom, but I'm not quite sure he's in touch with Nigerian politics. African diasporans often support people in their countries of origin through remittances. This has been highlighted by some of the previous contributors' talks. But just how much? Let's look at the next slide. So IFAD estimates that the annual remittances to Africa by diasporans is approximately $40 million. Billion. However, because of the informal nature of these remittances, some studies have shown that it could be 4 to 5 times higher. So if you do the arithmetic, it could be as much as $160 billion. These, like our colleagues stated yesterday, can be like envelopes of money being sent back to the country, which is really off the record. So this is something that it's huge amounts, but it's not on any paper trail. Remittances make up to 5% of Africa's total GDP. Now, it's estimated, and somebody highlighted this before, that remittances are higher than the total aid received by Africa from developed countries. Mind you, this aid excludes a lot of, the calculation for this aid excludes things like projects from the East, China, coming into Africa, and projects from Gulf countries like the Saudi government contributing to development of mosques and other things. When they calculate these things, they don't add in those estimates. But we are contributing back to the motherland. The unfortunate thing is, the interesting thing is, with annual aid coming from the West, a lot of it is embezzled actually, so it still comes back to the West. And then they go behind our backs and call us fantastically corrupt. Yeah. So which countries have the highest amount of remittances from their diaspora? As you can see from this graph, Morocco has about $6 billion annually, followed by Algeria, $5.4 billion. Nigeria comes in third, and Egypt has $3.6 billion going back to the country. Sorry, say again? Lebanon. Well, I looked at the highest four. However, with these remittances, we tend to find that the top 4 countries that I've listed here, although these amounts are huge, as a proportion of the GDP of the country, they're not so high. When you look at these countries, one of the things, they have very large economies. So these huge amounts actually are not quite a large percentage of their overall GDPs. When you look at these smaller, less wealthy countries, there's a far larger dependence on these remittances as a percentage of their GDP. So Eritrea, that has a huge population outside, external remittances is about 38% of their GDP, about 40%. Cape Verde 34%, Liberia 26%, and Burundi 23%. So what are these remittances being used for? And we're coming to the crux of my own aspect. Well, most people would just assume that people send money back to the countries for consumption, to sustain relatives over there, and to help out with the paying of rents and so on and so forth. Looking at the literature, Eritrea, where up to a quarter of the population actually are in the diaspora, a large chunk is spent on education, payment of school fees, and so on and so forth, which is actual human capital development. A World Bank study in 2011 focusing on Nigeria and Kenya shows that they spend much less as compared to countries like Eritrea on human capital, but much more on physical investments, buying land, building houses, and improvements to farms, and so on and so forth, about 37% and 30% respectively. Another paper looking at Ghana shows that spending among families that receive remittances spend less at the margin on food and more on education. So it's a mixed bag from different regions. Every country has their priorities when it comes to spending on remittances. However, what I'm interested in is how much is being spent on healthcare. Some of you that send money back home might tend to agree with me that everything goes on, either human capital, paying school fees, and so on and so forth, goes on buying land, sometimes buying houses for you, the person in the diaspora, and they tend not to pay healthcare insurances or save up for healthcare. And when there's a sick member of family or somebody has a problem, they revert to the person sending the money for a special package for hospital bills. We need to recall that in Africa, a large proportion of family healthcare spending is done out of pocket. There are very few countries that have a very well-established health insurance scheme. They have these on paper, but the coverage, I give you an example, the NHIS in Nigeria, a friend of mine that started a health blog sent a tweet to the NHIS asking how many people are covered by the NHIS. That's the Nigerian version of the NHS here in the UK. And the answers were so vague. They were beating around the bush. Finally, an answer came on the Twitter account that that's a security question and he cannot answer that to anybody that is asking it. Just how many people are covered? You're supposed to push that out. That's information that helps you show how well you're doing your job. So it's a huge problem. Now, if you look at a country like Somalia, diaspora they have diaspora spanning all continents of the world. Spending is less eagerly done on healthcare and education because simply they feel these are not available, or if you spend on it, it reflects poor quality. So the continent has the fastest growing young population in the world. Investments in human capital, healthcare and education have potential for the greatest return on investments in the future. So why are we not looking deeply into investing back specifically on healthcare? In 2001, the AU met in Abuja, Nigeria, and agreed on the Abuja Declaration to make at least 15% of the country budgets available for healthcare utilization. Now, even the host country, Nigeria, has never, since 2001, made up to 15% available. I don't know about Sudan, Egypt. If anybody has those statistics, I'd be interested to know. But we're not living up to expectations at all. When you look at, anyway, I don't have that much time. So what are the healthcare needs of Africa? I'll be talking a lot about Nigeria because that's basically what I know the most. Lack of formal universal healthcare coverage and insurance, especially for rural areas where majority of Africans live, and I'm very happy that my colleague spoke about diasporans going directly to the rural area to do jobs. In countries like Nigeria, you find that over 80% of the HIV response, Nigeria has the second largest population in the world of people living with HIV, second to South Africa. 80% is funded by US money, donor funding, PEPFAR, the Global Fund for AIDS, TB, and malaria. Every country has some form of aid, but this aid is not forever. It's not indefinite. These are grants. There's a huge dearth of skilled manpower in healthcare on the continent. There are emerging epidemics like Ebola, which have actually taken a toll on the trained healthcare workers there. In West Africa, healthcare workers died in large numbers because of their altruism in treating Ebola. Insecurity in countries like Somalia, Libya, Nigeria, Mali, etc. has led to destruction of large proportion of the infrastructure in healthcare. And when I'll show you the next slide, it's something from my presentation in the WSD conference. I did an assessment of the destruction caused by Boko Haram in the state I'm from, where it started. And up to 50% of healthcare facilities are completely destroyed because of that insurgency. However, we find a paradox. Nigerians spent $1 billion, that's 690 million pounds in 2013 to 2015 on medical tourism. So they're bringing the money back here. And, and we keep complaining about terrible indicators in these countries. This is just, I'm not going to go into every picture. This is a general hospital in the second largest city in Maiduguri, and this was, it's now an internally displaced people camp, and it's part of the work Center for Alternative Sustainable Livelihoods does right now. We're providing ad hoc healthcare to fill in the gap. So all over Africa, these stories are there, these needs are there. But then we have such a huge diaspora, and we're remitting funds for so many things, but the funds are not going directly into healthcare. So what can we do? This is a graphical representation of what was destroyed in my region of the country. So what can we do? Well, the first thing is to think about health insurance. The creation of HMOs that deal specifically with funds from diaspora is a possibility, and I welcome all sorts of contributions. Yesterday somebody asked if there's any country that has a very good example of diaspora engagement. I personally feel when it comes to healthcare, India seems to be setting the pace for taking back to the home country. Indian doctors have been trained all over the world, and they really are fueling a revolution in healthcare in India. So it's something that most of our countries in Africa can do with the numbers that we have. And it's something that like we were saying, we don't need to reinvent the wheel. Let's copy something that has been done. Try it. If it doesn't work, at least we can tweak it and go back and try it all over again. India has groups like the Apollo group created by Dr. Reddy. Right now, he's worth, I think, $670 million. But in 1983, he went back and created a private hospital group that actually revolutionized healthcare provision in India. And what they call it democratization of healthcare provision, where it left being an elitist thing and became something that was really accessible, even though it's for profit. It's not altogether charitable, but it has provided healthcare to about 30 million citizens of that country. There's also a model called the Forever Care, which I'm trying to experiment in Nigeria, which I'll show you in the next slide. It's one of our major concerns when we live in the diaspora is what is happening to these people, our parents. That's one of the things that keeps us awake at night. When you know your healthcare system is not like the US, where you pick up a phone and call 911 and they're there in 5 minutes. So what we're trying to do is set up a group of specialists in the country. We have the primary care physician. We have, and this, I'm copying this from the Indian model actually. We have a specialist in geriatric care. We have nurses, rehab therapists, the best diagnostic services in the city, or in the state, as the case may be, pharmacies, and then family members as a support group. Now this network, and then you have a specialist in the country of origin, in the country of residence of the diaspora member. Now this network is paid for by a member of the, okay, this is practically the last slide. It's paid for a member of family monthly from the diaspora. It provides home visits, it provides physiotherapy, nursing visits, whatever is required by the elderly here. And it's something that I'm trying to see if I can expand to not just being a family unit issue, but something that can be taken to a region. For example, the region I'm from has lack of healthcare, so I form a company and bring specialists into that region. When second opinions are needed, you get somebody from the diaspora that's an expert to take a look at maybe radiological slides and so on and so forth. But this is something that is dedicated specifically to healthcare. So the remittance goes directly to the healthcare of these people. Other ways we can step up. Diaspora bonds. This has been very successfully used to fund national projects by Ethiopia, Israel, and these mobilize huge amounts of money. This is not just for healthcare, for dams and so on and so forth. Ethiopia floated a bond recently of $5 billion with 5-year maturity. Services, I've seen services offered by Sudanese doctors, and it's an excellent thing. Encourage training overseas. I've seen so many presentations on training, but sometimes it's not so good to be apolitical. Sometimes when your presidents come, you need to put pressure on them and ensure that they change what is going on. They need to know that they're a group of people that are looking at what is going on in the country and put pressure on them. We're a large number. We all have passports. We can still go back and register to vote. So they need to know that some people are looking at things from an objective point of view and are still scoring them low in performance in their countries. Thank you. So, like I said, diaspora is very large and is growing more and more important in economic and healthcare development in countries of origin. It's time for us as Africans to wean ourselves off all this donor funding, really, because it's really not having an impact. The money it's like a sieve. The money goes there and comes back. The skills are out there, and we need to more formally transfer it to the motherland. I leave you with this. Cuba has 90,000 doctors for a population of 11 million, although they have been under grinding United States sanctions for 50 years. They have a better public health system than both the United States and the UK. They have twice the number of doctors per patient, the ratio. Yeah, and they're better than the people that try to put them down. So there's no reason why Africa cannot unite and improve our healthcare status. Thank you very much.